My name is Kathleen Kieran. For those of you who don't know me, I am a pediatric urologist at Seattle Children's Hospital and an associate professor of urology at the University of Washington. This afternoon, you may be wondering why we have two people speaking. It's because we're talking about voiding dysfunction, bladder and bowel health. And so I will let my colleague, Dr. Ambartsumyan, introduce herself.
Hello, everyone. Thank you again for inviting me. I'm very excited to be here today to talk about poop. It's all about the bowel and bladder health. My name is Lusine Ambartsumyan. I'm an associate professor of pediatrics at University of Washington and the director of the gastrointestinal motility program here.
Great. So before we get started, I'd really like to thank Dr. Kopp for doing this in general and for inviting us to give this talk. And I will say that we do have a fairly packed hour here. We have about 45 minutes of lecture followed by 15 minutes of questions. Please put your questions in the Q&A and we will do our best to answer them at the end. And as Lusine and I were talking about earlier, this is a bit of, no pun intended, it is a bit of a dry topic, but we will try to make it as interesting as we can as we go along. And if there are questions, please do put them in the Q&A. So without further ado, sadly, we do not have any disclosures. And one of the issues with incontinence is that we all know that, there are lots of jokes about it. I think if you look at this slide, that's the picture on the left side, that I think we all have gotten this card from some well-meaning resident or fellow or visitor at some point, that's the incontinence hotline, can you hold? And we laugh about it, but incontinence is actually a very serious issue. It costs millions of dollars a year, and it causes a great deal of stress to families and to children. On the right side, you may recognize this. I don't know if any of you are familiar. This is the papyrus. And so this is from many, many years BC, but the first actual formal academic manuscript on incontinence was published in 1915. And in the century since then, there's actually been substantial improvements in our understanding of voiding issues, what happens normally, what can happen abnormally, and also the wide range of manifestations of voiding issues. So our objectives today, knowing that this is a very broad topic, are going to be threefold. The first is to briefly review the anatomy and physiology of the lower urinary tract. And I know that as pediatric urology fellows, for most of you, this will be a review, but since these are commonly tested on both the oral boards and the written boards, I want to make sure that there are some slides that you can look back to. In addition, we'll talk about red flags and ways to differentiate between organic and functional elimination disorders. And finally, and this is Lusine's area of expertise, we'll be talking about the evaluation of childhood functional constipation as it pertains to bowel and bladder dysfunction. Because as urologists, we're really taught how to manage the urinary issues, and the poop really, it just scrapes the surface. So we'll talk about that in more detail. So lower urinary tract dysfunction, I like to think of this as the great imitator. We call syphilis this great imitator, but lower urinary tract dysfunction really has a wide range of manifestations. Your patients classically, but don't always present with incontinence. So they may come in with the recurrent UTI. We've all seen patients where the parents say, as soon as I finished the course of antibiotics, it was about a week later, and he or she had another urinary tract infection. Kids who are running to the bathroom, they have very severe urinary urgency or urge incontinence. And then there's the pain, the penile pain, the testicular pain, vaginal pain, vulvovaginitis, and then dysuria. And all of those problems exist along a continuum that can often be treated in the ways that we treat elimination dysfunction. So I wanted to just touch briefly on some myths about lower urinary tract issues. And the reason I bring this up is our understanding of how the lower urinary tract functions by itself and in concert with the bowel has really grown in the last century, but also the last couple of decades specifically. But yet I think at every meeting that I've been to in the last 20 years, I hear one of these statements, at least once, from someone who is a well-respected member of the pediatric urology community. And so first myth, there's no problem if the child is dry. And so being dry, sorry, my dog obviously thinks that's not correct. So being dry is a great endpoint, but it's not the only endpoint. Being dry doesn't mean that everything is perfect. The second myth, which I think is a little more well known as a myth is that the child is incontinent on purpose. And every year we see that there are many children who are punished corporally or emotionally abused by caregivers because of incontinence and voiding issues. Third myth, the bladder is too small for the child. This is not necessarily true unless you have, excuse me, I'm gonna deal with the dog. Come here, buddy. My dog loves Zoom, so we'll bring him up here. That the bladder is too small for the child. And so this really isn't true unless you have a neurologic or another issue that's going on. It's typically not true if you have functional issues. So there's not really organs that don't grow in concert with the rest of the body in a way that doesn't suggest a more significant problem. The fourth issue is that offering access to a bathroom is sufficient. It's certainly necessary. It's not sufficient to address voiding issues. These kids generally have bathrooms at home, but being able to know when to use the bathroom and being able to coordinate that is actually what's really necessary to achieve social continence. And finally, urethral dilatation. This was commonly a procedure that was performed probably 30 or 40 years ago, but I've still seen some parents come in and ask about this because they had it done to them as a child. And so urethral dilatation in functional urology complaints generally is not helpful. So this is the slide that I'm putting up for all of you to look at the neurologic input in terms of the neurotransmitters and the nerves that help you void normally. It's clearly more complex than this, and I'm not going to get into the finer nuances of it. I do want to talk about kind of troubleshooting what issues arise with voiding issues before Lusine talks about the contribution of bowel health. But I do want to point out that we know that the pelvic nerve supplies the parasympathetics, the hypogastric nerves inform the B3 receptors, the beta 3 receptors, and then the pudendal nerve and the somatic input from that feeds the external urethral sphincter. So you really need all three of those systems to work. And I put this up here because this is the best picture that I could find from the Fowler paper that's referenced there because again, this is commonly tested on the boards. On the right side, you will see my incredible oversimplification. These are the pictures that I draw when I give talks to the residents. These are the pictures that I give when I give talks to families or when I give CME talks. Because basically, you know, yes, the kidney doesn't plug into the top of the bladder. It doesn't really look like that. But your kidney makes urine. It brings the urine down the tube. It goes to the bladder. The bladder is a reservoir. It is a balloon. And just like a balloon, if you fill it, at some point you're going to feel that stretch, that pushing back that says, I'm full. You probably don't want to put more in me. And then you have to figure out how to get whatever's in that balloon out and completely empty it. And the way to do that is to release the outlet obstruction that is there and to orient it in a way such that everything will go out in the desired pathway. On the right side, you'll see I don't draw a brain, but there's a message there to your brain that kind of helps you modulate those activities and make that need to void be done in a socially continent manner. So your bladder will feel full. You can either relax these muscles to void or you can squeeze them, and that's like a little snooze alarm that you'll see that you could tighten those muscles, and that gives you some time to find a bathroom. But ultimately, if you don't go to the bathroom and you let things fill up more, the muscles here will start to contract even more strongly. And then you can hopefully inhibit these intrusor contractions in order to find a socially appropriate time and place to empty your bladder. So I want to touch briefly on meaningful stimuli. So meaningful stimuli are those that are different from the background, that are intermittent, and they're episodic. So one example of this might be a railroad crossing. So railroad crossings have flashing lights. So the lights flash. They're not just one color all the time, continuous. They have beeping sounds. So there's a lot of basically the aural equivalent of something flashing. And there's also many visual cues. There's barriers that come down. There's barriers across the top of the road as well. And the reason for this is that if you have continuous input to any nerves, they will fatigue over time. So the analogy that I give my families is that you don't really optimize your bladder function then if your bladder always feels like it's a little full, or it doesn't know when it's full, or the input is such that going back here, you don't know how much is in your bladder and how that relates to full, you don't know how relaxed or tight your pelvic floor is, or you're unable to interpret those messages, then having a message that tells you that you're really close to full isn't different enough from your background to make you go to the bathroom. So let's talk about some of the common urinary issues and how they relate to my little line drawing. So urinary urgency typically presents as an immediate urge to void. So these are the kids that you see that are squatting, they're crouching, they have their heel in their perineum, they are trying to get to the bathroom in time. And so the heel in the perineum is called Vincent's curtsy. Many times these kids will also have recurrent urinary tract infections. Classically, these are 5 to 7-year-old girls. In my experience, I see a lot of young boys that are about the same age with this as well. So what happens here is the bladder is, the muscles are contracting and they're trying to hold this in. They're physically holding the urine in. The tennis ball. With stress incontinence, it's a little bit of the opposite problem, but the problem here is with outlet obstruction or lack thereof. So stress incontinence is actually very common. There was a study, the first study of this was actually about 40 years ago, but more recently there have been several studies that have shown that about a third to a half of female varsity collegiate athletes, so very strong athletes, very well, very in shape athletes, have stress incontinence, and they have it on a regular basis. And so when you drill down a bit more on this, higher impact sports seem to have higher rates of incontinence. It seems to be when you're really landing hard, so jumping, doing something that's more, not only higher impact, but a little bit more plyometric. So 2/3 of gymnasts will have reported stress incontinence, whereas golf, typically not a lot of jumping or squatting or plyometrics. In golf, we didn't see anyone that reported stress incontinence there. And so the challenge here is that the bladder typically works okay, but you can't maintain a tight enough seal, so to speak, on the outlet, particularly when there's a lot of pressure from above. And the picture that I like to draw for people for that is, your abdomen is a cube. If your back, your obliques, and your abs and your diaphragm are all really strong because you're an athlete, your pelvic floor is going to be the relatively weak part of that box. So what happens if you have a box that's strong on 5 sides and the 6th side isn't so good and you drop it from a height? It's going to break on that weak side, which happens to be the pelvic floor, the bottom part, and you're going to leak. And then finally, I just want to say a few words about the bladder and brain connection. And this is something that I think is being increasingly studied, but this is particularly important when we deal with kids with nocturnal enuresis, because if you make urine, it goes down the tube and it fills the bladder up normally, and then you're able to keep this outlet tight, in theory, you can stay continent all night. The challenge is if you start to feel full, but again, you don't realize that as a stimulus that is different from the background, and you're also sleeping so that this outlet here, you're relatively hypotonic, so that outlet's not as tight, and you're a deep sleeper, you won't necessarily wake up and you will leak urine. Now, one of the challenges with nocturnal enuresis is that there's certainly other factors that go into this, but the key part of this is that the kids are relatively hypotonic at night, but also this message doesn't work as well. We also see that there is some attentional issues in kids who have, for example, autism, ADHD, who might not either recognize that the bladder is full or they don't necessarily act on that need to go right away. The bedwetting alarms, in theory, they act on this Pavlovian principle that your bladder contracts, your detrusor contracts, you will leak, the alarm gets wet, the alarm goes off, it wakes up your very tired parents, they wake up the child, and you have to go to the bathroom. And so in a perfect world, which admittedly we don't live in, those bladder contractions should wake you up as a child, and you should be able to go to the bathroom and empty your bladder. Now, the challenge with this is I tell people, if your child's a really deep sleeper, If your child doesn't have great elimination habits during the day, then we're going to see potentially that it may take a little bit longer to build that connection, and they may wet the bed multiple times per night. And so I think the assumption is often that when you wet the bed once a night. And that's not necessarily true. You can wet it, 5 times, 10 times, 3 times. And the challenge is you got to get up every time as the parent and shut the alarm off, wake the child up, take them to the bathroom. And so you really want to reinforce this connection, but by not getting up, you're reinforcing the opposite connection. So it's really most effective when elimination habits are optimized prior to giving the bedwetting alarm. I do want to just touch briefly, because this is often, again, tested on myogenic detrusor failure. This is when the muscles stretch to the point that they no longer interdigitate well. And then this is an end-stage bladder where you can't generate a strong contracture. And so the bladder often will not empty very well, or you need to use your abdominal muscles to strain to void. This is something that we see with neurogenic bladders. You will also see it in kids who have posterior urethral valves or very severe outlet obstruction. So in terms of the evaluation, the big question is going to be, is this organic or is this functional voiding issues? One big part of the physical exam is going to be looking for red flags. So you want to look for things that suggest neurologic or muscular issues. So the children have any problems walking? Do they have any problems stretching? Do they have any problems moving? Do they have symmetric muscle tone and strength on both sides? In addition, think about sudden severe urinary retention that either doesn't get better or it recurs. So for example, a prostatic rhabdomyosarcoma is someone who might present with urinary retention, but the usual, few days of catheter drainage, working on the pooping, and then they're back in the ER with the same problem. That's somebody you might want to think about imaging. Comorbid conditions. Does the child have, for example, diabetes insipidus, and they make a lot of urine? Is there someone who has diabetes and so they have a lot of sugar in their urine? Do they have blood in their urine that would suggest maybe a stone that might account for, that's in the, passing through the ureters and is in the wall of the bladder at this point and is causing some urgency and frequency? You can also gather a lot of information through voiding diaries. Traditionally, voiding diaries are 3 to 7 days. Some people do use them for up to 14 days. The more recent research has suggested that voiding diaries that are only 3 days in duration are adequate to capture as much information as the 7-day diaries. I will say personally, I don't use voiding diaries as much as I probably should, because my experience has been that a lot of my families tell me that they're filling it out in the waiting room. They forgot to do it. So it's really important to do it, but do it in real time. Wanted to talk about UroFLO and PVRs as well. If you look at the International Children's Continence Society recommendations, they do recommend evaluating the flow rate and what the flow dynamics look like. So these are basically non-invasive urodynamics where you're not measuring bladder pressures. A normal voiding pattern is a bell-shaped curve. On the upper left, you'll see a tower shape. That's a very strong voiding contraction. On the right side, you'll see interrupted. This is more consistent with abdominal straining, although often you'll see higher peaks because there's a really high pressure that can be generated. And on the bottom right, you'll see staccato. And so the key with staccato is staccato never gets all the way back to baseline, interrupted does. And then the plateau is a very flat curve that suggests a stricture. So initial management of what you think is a functional lower urinary tract issues, your patients come in with incontinence, with recurrent afebrile urinary tract infections, with bedwetting, and you don't see any of the red flags on your evaluation. You don't see any marks on their lower spine, you don't see any discolorations, you don't see any deviated gluteal cleft. There's nothing that looks like there's anything more going on. Take the advice of Margaret Boyd, who is my nurse practitioner that worked with me in Iowa. Her mantra was drink a lot, pee a lot, and poop. So you want to drink enough that the kids can say that their urine is light yellow in color, and I actually give them a little paint chip from like Lowe's, and I'm like, you need to be at light lemon. We don't want to a goldenrod. And the reason for that is that as kids go through certain growth spurts, they will have a lot of waste products that get passed out in their urines. They need more water to wash that out. Remember, the kidneys are meant to carry your waste products away from your body. Pee a lot. If you're drinking enough water to keep your urine light yellow in color, you should be able to void every 2 hours. So we really want to encourage peeing first thing in the morning, peeing last thing at night before you go to bed, and every 2 hours during the day. And I tell parents that the best results with this come from modeling where everybody goes to the bathroom because it's 9 o'clock or it's 11 o'clock. Waiting till the children need to go to the bathroom till they feel like they need to go is often where they'll have wedding accidents and get very discouraged. So much like feeding your children before they become ravenous, dinner's at 6. We eat at 6, whether or not everyone's like really, really hungry. Keeps kids on a schedule, and it prevents the bladder from getting overstretched. So then when it does feel full, that's a very different stimulus than what they normally feel. And then finally, and this is really Lucine's area, pooping. So Bristol's 5 or 6 stool every day. So we want something that's not formed, and we obviously don't want them having stool incontinence. On the right side, I've referenced a couple of papers, and there are a few more that are out there, but these are a couple of the big ones that really discuss that school nurses and school teachers, regardless of their level of teaching or what kind of school they're in, they really don't have adequate training in terms of how to manage pediatric lower urinary tract issues. Much of what they know is actually passed along by other people in the same job. So older teacher tells younger teacher how to manage things, and the same with nurses. And so what happens is their lore becomes dogma. So this is really an area where it's really important to partner with your local school systems and your local nurses and teachers to make sure that they're educated properly about the importance of going to the bathroom, that just having the bathroom in the classroom isn't adequate, having timed schedules, and also having bathrooms that are safe and clean enough to use. With all of that behavioral modification, meaning they drink a lot, pee a lot, and poop. That is the initial recommendations from the International Children's Continence Society, and there are several monographs, depending if you want to look at daytime or nighttime incontinence, but really those are the big 3 that they recommend. If you do that, and kids are consistent and they do it well, about 1/3 to 1/2 will have improvement with that alone. But 1/3 of these will recur within a year. So very important to frame this as a lifestyle change, not as a do this, things will get better and you can go back to what you were doing. If that's not effective, then I typically recommend adding in pelvic floor exercises. We'll talk a little bit about the difference between biofeedback and pelvic floor physical therapy. But doing all of those things and then really drilling down on the voiding diaries, this is where I use those. And pelvic floor relaxation will raise your success rate up to about 90%. So the key takeaway from this is that medical therapy, which is often started by pediatricians and often started by urologists, this is not a first-line therapy. This is an adjunct to, not a replacement for, the behavioral changes that need to take place to help kids with lower urinary tract issues. And just a word on pelvic floor biofeedback training, because Lucine's going to talk a little bit later about physical therapy. Pelvic floor biofeedback is typically performed in the hospital, often performed by nurses. Pelvic floor physical therapy is performed maybe not in the hospital, often in an outpatient clinic, but typically performed by trained physical therapists who have done additional work in pelvic floor physical therapy. Both of them require very motivated children and parents. Again, this is muscle training. This is not a one-time treatment. Again, better results if your elimination habits are optimized. If they have GI issues, I don't do biofeedback training for kids with lower urinary tract issues. If they have strong GI issues, I send them to pelvic floor PT. It really depends on the level of commitment, the level of training, and the level of engagement, how much success you will have with this. Pat McKenna has done a lot of work on using animation as an adjunct to the biofeedback. And he found that, I don't know if any of you have seen this, you can see have like, I don't know, a dolphin jumping through a hoop or a space shuttle docking at the space station, things like that. But those visual cues and that kind of video game mentality really does help to engage the kids more. And in one study, up to about 90% of those patients will have symptomatic improvement. But the key with this is that it's not necessarily durable. You need to make sure that they're not just engaged because they're watching something happen on the screen, that they're able to tie that into how they relate to their muscles. So other studies have shown that similar rates of symptomatic success, and if they did not receive treatment with animation, but they did find that there were differences in voiding dynamics afterwards, specifically the post-void residual, and that improved more with the animation. So something to just think about why the animation works. I'm going to turn it over to Lusine now, because the bladder and the bowel, as you can see here, are closely intertwined, and I'll be happy to take any questions at the end.
Hello, everyone. Thank you. This was actually a little background. This was a cake that I had made at the end of my fellowship to thank all of the urodynamic stuff and the urologists who helped me complete my fellowship project. And of course, always, the bowel and the bladder are forever friends. With moving on to the rest of our talk, I just wanted to highlight specifically this the study that I was fortunate to be part of, where we actually were able to highlight and demonstrate the physiological correlate between the bowel and the bladder. And essentially, we performed a prospective study where the patients underwent a combined urodynamics and anorectal manometry study. And the aim of the study was that we were going to see the effect of rectal distension on bladder dynamics and the effect of bladder filling and voiding on rectal dynamics. We designed a customized system where we were able to simultaneously capture not only the urodynamics parameters, but also the anorectal pressure changes as well. And we did 2 phases of fill. The first phase was when the rectum was not distended, and then the second fill was when the rectum was distended, in that order. We're able to demonstrate that the post-void residuals when the rectum was distended was actually lower than when the rectum was not distended. And this was important because it really physiologically highlighted what all of our urology colleagues have been telling the GI physicians throughout so many years, is that the presence of a stool in the rectal vault causes a significant effect on the bladder in its capacity and the bladder dynamics. We know that the patients did not effectively empty their bladder when the rectum was distended. These patients who didn't empty the bladder and had increased post-void residuals were also the ones who had increased association to having urinary tract infections. In the following graph, you can see the bladder and abdominal pressures during voiding with the rectal balloon distension. The solid lines represent when the rectum was not distended, and then the abdominal and the bladder pressures when the rectum was not distended. And then the actual the divided line you can see is that represents the bowel and bladder, the bladder and abdominal pressures when the rectum is distended. Here you can appreciate that the pressures were actually at voiding were significantly higher, the bladder and abdominal pressures when the rectal balloon was distended. Here we can demonstrate that when the rectum is distended, the patients have to generate higher bladder pressures and they have to strain more in order to void. We noticed that during voiding, the Detrusor pressures were much higher than one would anticipate it to be just by straining alone. So then it was speculated that the rectal distension may possibly elicit some type of intrinsic bladder reflexes to increase the bladder pressure in order to overcome the mechanical obstruction that is posed by the presence of the stool in the rectal vault. Contrary to most people's opinion, defecation is a very complex interaction between the extrinsic and the intrinsic innervation, anatomical factors, sphincter function, colonic transit, rectosigmoid function, stool consistency, and sensation. The same physiology that underlies with how the bladder empties and fills is very similar to the same sacral nerve complex and the pudendal nerve control also the internal anal sphincter and all of our colonic and anorectal motility. And we also have the enteric nervous system, which is essentially what we call as the third brain of the gastrointestinal system that affects the movement of stool passing through. One important thing that I want to highlight is that the diagnosis of constipation is actually based on an internationally devised criteria known as the Rome criteria. And that is based on different types of age groups. Here on your left-hand side, you will see the criteria for functional constipation in children less than 4 years of age. On the right-hand side is the criteria for those greater than 4 years of age. And then we now, with the Rome 4 criteria, we have criteria for patients who are even less than 9 months of age to diagnose them with functional constipation. But even with these criteria, it's quite tricky to diagnose somebody with constipation because you can technically be stooling on a daily basis, but yet be severely impacted. So it's not just filling the criteria, but it's also taking a very good history and being able to capture the entire picture. The evaluation and treatment of functional constipation is also based on European and North American Society Pediatric Gastrointestinal and Hepatology guidelines. So essentially the ESPGHAN and the NASPGHAN are responsible for highlighting all of our guidelines for evaluation and treatment. They're evidence-based, and we will review some of these guidelines as we go through our slide set. The way I approach patients with constipation is, essentially this is my mantra. We talk about that we always do a comprehensive history. We do a very detailed physical exam, especially a neurological exam, and we use the symptom-based Rome criteria to diagnose someone with constipation. But then we also, in the back of our minds, keep track of, well, what disorders are we trying to rule out that mimic defecation abnormalities, and then what types of complications are we looking for? So every time we see them in clinic, 3 months, 6 months, 9 months, we're constantly reevaluating them. We assess them, we put them on a treatment, and then we ask ourselves, is the treatment effective? And if not, why is it not effective? Are they not following the actual guidelines that we are giving them? Or is it that their actually constipation is mimicking something else, and the constipation is only the end products? So while most pediatric patients and the parents worry about, well, what is actually causing the constipation, we always tell them that we are constantly reassessing for organic disease. And we can discuss some of these as we go forward. Now, alarms, I think one of the more important things to know is that what alarm signs and symptoms exist in patients with constipation that should really trigger you to worry and send a patient for GI. Now, constipation really early in life, less than 1 month of age, should be very worrisome, especially in patients who didn't pass meconium under greater than 48 hours of life. Those are patients where I worry that they may have Hirschsprung's disease. Essentially, if someone has vomiting, abdominal distension, poor weight gain, and questionable meconium passage, that's a patient that has to be immediately evaluated. The one interesting to note about this is that everybody has this misnomer that Hirschsprung's disease always presents in the first month of life. Actually, only 60 to 70% of patients are diagnosed by the age of 4. So there are a significant proportion of patients that go missed too. Patients who have perianal fistula or abnormal position of the anus, we worry about anorectal malformations. And I did mention before doing a very thorough neurological exam is important, because if they have an absent anal or cremasteric reflex, or decreased lower extremity tone or reflexes, or they have spinal tufts or sacral dimples or gluteal cleft deviation, then we worry about a neurological spinal anomaly. And also in cases where there's extreme fear during anal inspection and also anal scars, then we worry about signs of sexual abuse. What are the goals of our treatment? I mean, essentially, when it comes to bowel and bladder health especially, I want to make sure that we facilitate colonic emptying, and more specifically, rectosigmoid emptying, so we do not have that stool sitting in the rectum pressing on the bladder. We also want to ensure that the patients are fecally continent, and ultimately preserving the colonic neuromuscular integrity and making sure that their quality of life is overall improved. Now, some of the non-pharmacological treatment options include dietary fiber, and that includes soluble and insoluble fiber. Just remember that actually there is a real difference between the two. Soluble fiber will make your stools much more bulkier. So when somebody's really constipated, putting them on soluble fiber may not be your best bet. It's better to put them on insoluble fiber because it binds to bile acids and it can make the stools a little bit looser. But if you actually have fecal incontinence, then putting you on insoluble fiber may not be your best bet. Of course, fluid intake, physical activity. There's a question about probiotics and prebiotics as well that some studies have shown that it's helpful. Behavioral therapy and biofeedback. The one important thing to note is I always tell the parents, that all of these things are critical. Every child has to do them. And in 60–70% of the patients, this will just by itself be enough to be able to help their symptoms. But when somebody truly meets our Rome criteria for constipation, studies have shown that only doing these is not going to help with their constipation. So you definitely need to add medical therapy as well. So while this is a must, and this I put this on patients as their responsibility for the parents to do this, and their medical option is really important. Now, it's different from urology. Biofeedback for pediatric constipation has not been shown to be helpful at all. So that is actually something we don't particularly use very much of. Shockingly, it works really well when they're adults, and somehow it does not work well when they're in pediatrics. However, a newer thing that Dr. Kieran discussed is the pelvic physiotherapy. There's 2 studies that have been published that have shown some promising results. For the first one on the top, Beninga et al., this is a study from the Netherlands. They actually did a multi-center, a randomized controlled trial of 53 children, and they used standard medical therapy, which is behavior therapy, education, laxatives, and then they used standard medical therapy and pelvic floor therapy. So patients with pelvic floor therapy actually had 92% improvement in their symptoms of constipation, which is quite amazing compared to 63% who were just in this standard medical therapy. They also showed improvement in behavioral and also quality of life. The study on the bottom by Chumpitaze et al., who's actually used to be a former colleague of mine, and that is mainly looking at physiotherapy in patients with fecal incontinence. This is a retrospective study that showed approximately an 80% improvement when patients did pelvic floor therapy for greater than 1 month in their symptoms. So there's promising hope, but we have to be careful about sending them to people who are truly pediatric trained, because adult pelvic floor therapy is very different than pediatric pelvic floor therapy. Now, what are some of the pharmacological treatments? We have the osmotic laxatives, which is your polyethylene glycol or the Miralax. Everybody loves Miralax, but of course there's these new studies and patients may worry about autism. Those have not been proven, and we tell patients there's no link between Miralax or autism. There's also lactulose too, but that can cause a lot of gassiness, and there's milk of magnesia or magnesium hydroxide. So polyethylene glycol has been shown to proven to be more effective than lactulose, milk of magnesia, or mineral oil. However, in patients who have predominantly fecal incontinence because they are retaining a lot of stool, I shy away from Miralax because all it does, it makes the stools more loose. So when you have a rectum that doesn't empty or a colon that moves slowly, by making what's inside of it looser, all it's going to make you do is to leak more. How do you empty a bucket that's overfilling? You empty it. You don't make what the contents inside it more loose. So then in those cases, what I like to move forward to would be stimulant laxatives, such as Senna and Bisocodyl. You may hear that the stimulant laxatives can cause colonic neuropathy or myopathy. Those have not been proven. Those studies are based in 1960s mouse models, and they truly have not shown any type of neuropathic effects. But our adult colleagues definitely shy away from Senna and Bisocodyl. Of course, in some of the patients where they do have rectosigmoid dysfunction or colonic dysmotility, I do use enemas and suppositories, but you have to be careful using enemas or putting patients on chronic enemas, because you don't want to use sodium phosphate enemas in somebody with a single kidney, or if somebody has any renal dysfunction, or if somebody's pooping 1 time a week, you don't want to be using magnesium-based products or specifically magnesium oxide, because that can cause electrolyte abnormalities in them as well. So while we sort to enemas and suppositories, you have to be careful that you're not missing an organic disease. One thing I was telling Kathleen is that I can make anybody continent. You can have Hirschsprung's, spinal cord anomaly, cerebral palsy, or a tethered cord. I could put you on enemas and make you continent regardless. And you would never know that the difference between all 3 of them, because they will always have predictable bowel movements. The key is that the enemas and the suppositories are a band-aid to the underlying problem. So while yes, we will make them continent, appropriate workup is important. The following is just a reference slide for you when you get the slides about the dosages. So it's, I know it seems overwhelming, but it's just a reference slide. Important rule of thumb is that if we are going to start medical therapy, you want to make sure that the end of the pipe is actually open. So you never want to pour more stuff in from the top, and if somebody has fecal impaction. So we like to do disimpactions. Either you can do a PEG-based or rectal enemas. This is 3 to 6 days. I think that's kind of mean. I mean, to give an enema for 6 straight days or make them be incontinent, I like to resort to 3 days of each of them. Maintenance treatments, again, polyethylene glycol or lactulose are going to be your best bet. And again, second line treatments are going to be your milk of magnesia, mineral oil, or stimulant laxatives. I really urge you to use the Bristol stool scale, because then we resort to using food groups, and then it just ruins bananas and like applesauce and ice cream for you. So it's best to just use the Bristol scale. We aim for 4 and 5. Studies have shown that if you have a 1 and 2, you're constipated. 6 and 7, you're most likely either having diarrhea or you're so impacted that you're just leaking stool. So again, Bristol stool scale is going to be really critical. Now, what are some of the stimulant laxatives? So senicides, it's anthraquinone laxatives activated by colonic bacteria. They work on your aquaforeign channels, increase fluid secretion, and alter colonic motility and transit. So if I really want to make somebody go and cause more effective colonic or rectal sigmoid emptying, and the Miralax is not working, I resort to Senna. It has been shown to actually benefit, especially patients with anorectal malformations. And this was a study done by Santos Jasso where they actually ended the randomized control study just because it showed such great efficacy. It's safe for long-term use. The only effect to think about is that in higher dosages, it causes perianal rash and blistering. How about bisacodyl? It's diphenylmethane laxative. Again, similar, primarily colonic action, increases fluid secretion, decreases colonic transit, and stimulates colonic motor activity. Again, now there's 3 great pediatric studies that's shown its efficacy and its safety. So we use it in pediatrics all the time. How about the duration of treatments? So there's no randomized studies that show one duration of treatment is better than another. So therefore, my rule of thumb is I like stability for at least 6 to 12 months. So usually I say that we need to continue somebody for 3 to 6 months, but definitely I can tell you from personal experience, when somebody's getting potty trained, do not take them off medication. Just keep them on medication for a year or 2 years. And then once they're potty trained and stable for 1 to 2 years, then you can slowly start to wean them off of the medications. But the weaning should be done over 1 to 2 years or 6 to 12 months. It should never be done right away. And the reason is because contrary to popular opinion, I mean, everybody thinks of functional constipation as like, oh, we gave the Miralax and now they're fixed. In reality, I explain to patients, it's like asthma. You just have it and we're just controlling it. So essentially, 50% of patients will relapse in a year. And another 50% will relapse in 5 years. And I mean, look at the patients referred to pediatric GI. I mean, 50% of them will remain without laxatives, but 40% will be symptomatic. And I always tell patients, 25 to 30% of you will be dependent on laxatives into adulthood. So therefore, we need to be very particular about this, and we need to be very good at controlling the symptoms and be very careful when we're weaning you off of it. So early intervention and adequate treatment is going to contribute to your successful outcomes. So how about for the patient who doesn't respond to treatment? So if they're not responding to treatment, it's a great idea to send them to GI, because we then get to worry about the 5 to 10% who could have an organic disease. And those are the ones when have possibly anatomical problems, neurological problems, metabolic, systemic, drugs or toxins. But usually by the time patients come to us, we are thinking about some neuroenteric abnormalities. So what are some of the evaluations that we go through in order to look through some of these options? Of course, anatomic, you just have to look at their bottom. They either have anal stenosis or stricture or they don't. Neurologic, if they have neurological symptoms, that's your tethered cord. Metabolic, we usually do chemistry, thyroid, celiac disease, cystic fibrosis screening. And drugs, we make sure they're not on medications that causes constipation. Then what is some of the evaluation? We'll talk about some of them listed in this slide. Oh, the great abdominal film, right? Multiple times a day I get phone calls. Well, the abdominal x-ray shows that they're constipated. It shows stool in the colon. And my response is like, well, thank God the stool is in the colon. Because if it was outside of the colon, we would be very, very worried. One of the important things we have to talk about is that the use of the abdominal x-ray is not recommended to diagnose somebody with constipation. So what I usually do is if you have somebody who has an unreliable medical historian, unreliable physical exam, you can't do a rectal exam, you worry about a fecal impaction, you're worried about colonic dilation, then I get an abdominal x-ray. And I think most people forget that they should actually look at the sacrum. This is an x-ray of a patient which was read as like full of stool, but actually there's no sacrum. So their constipation was neuropathy, not necessarily because they had functional constipation. So, and also the one thing to note is there's a great inter and intra-observer variability between patients when you show them the intra and intra-observer variability in radiologists who read the x-ray. And studies do not support that if you have symptoms of constipation and they're fecally impacted, and then you get an x-ray if that shows it. My rule of thumb is that if you're going to do an x-ray, you read the x-ray. You become proficient at reading your own x-ray, and then in that case, that's okay if you're ordering it. Or if you're going to give somebody an enema, or if you're going to give somebody a clean out, then that's okay to do it. But I would not rely on a radiologist to read your x-rays for you. The next is the contrast enema. We usually get a contrast enema to look for anatomical problems. We look for colonic caliber. Are they dilated? Are they redundant? And most importantly, we screen for Hirschsprung's disease, but of course it's not the ideal screening process because we do anorectal manometry, but we can see a transition zone and it helps with surgical planning. Anorectal manometry is like my urodynamic study. And what it does, it measures the neuromuscular integrity of the anorectum, and it tells me about spinal integrity and spinal control of the anorectum. A flexible balloon is introduced, serial balloon inflations are performed, and we've measured the involuntary and the voluntary properties of the anorectum. If somebody has a neuropathy on physical exam, their anorectal manometry, it shows neuropathic signs or symptoms similar to your urodynamics. Then we get an MR of the spine because studies show that 3 to 9% of patients with refractory constipation may have a tethered cord. But otherwise, if they don't have any of these findings, we do not routinely recommend an MRI. The next test, which is actually quite easy, is this little pill. It's called a radio-pack marker study. You take the pill, it travels through your colon, and then it either gets equally distributed, in which case, you know, then somebody has a slow colon, or it gets all trapped at the bottom in the rectum. Then you can say they have an outlet obstruction. Or it's a kid who has pelvic floor dysfunction, or it's somebody who withholds their stool, or all of it has passed, and they're having incontinence, not because they're retaining stool, but because they have what we call non-retentive fecal incontinence. So 15 to 20% of kids can have incontinence, not because they're constipated, but because they just have incontinence for another reason, and we have to do a further investigation. So this is a very easy, non-invasive way for us to see. And if the markers are spread equally throughout the colon, then we worry about colonic dysmotility. So then the next study would be to do a colonic motility study. And in that case, I put this long tube, I do a colonoscopy, put this catheter, which is, you can see a picture on your right-hand side, that's a very big colon. And if I put that catheter in the colon and I connect it to a machine, and then essentially what I'm doing is measuring the neuromuscular properties of the colon. And I see if it's a neuropathy, I can tell if it's a myopathy, if it's a segmental or total colonic abnormality. And this also helps me predict appendicostomy success for these patients. Also to see if I'm going to recommend an appendicostomy or not, or an ileostomy or not, depending on these colonic manometry studies. Of course, you know, when patients come to us and we have to do these more fancy studies and see, and if we discover that somebody has abnormal transit or abnormal colonic motility study, then our goals are a little bit different. Like, then my whole goal becomes, well, I need to really keep that rectosigmoid empty, and I really need to be able to keep them continent by making predictable bowel movements, and at the end of it, making sure that they're independent. There's a few things I have in my arsenal. I can change the consistency of the stool. I can change the transit, right? The consistency is by diet and different foods. Transit, I can give them senna. Rectosigmoid function, I can put them on enemas. Anorectal function and patient's behavior by pelvic floor therapy. And for these patients, then we resort to something, we do retrograde enemas, we call high volume enemas or peristine system. And then if they're successful of those, or if they're not able to tolerate it, but if they have an underlying colonic dysmotility, then we do an appendicostomy for these patients after they've gone through all of the testing. More recently, I've been getting referrals of patients who have been placed on enemas for urinary dysfunction without having any of the following workup. And some urologists prefer to do that. I just warn you against it because that means you have essentially you could be missing serious organic disease. So while yes, you can put somebody on enemas to create more effective rectosigmoid emptying, I just warn you that it's best to have more of a thorough workup so then Hirschsprung's disease or any neurological abnormalities or motility disorders aren't missed. So in summary, bowel and bladder dysfunction is common in children and has a significant impact on quality of life. The evaluation and treatment of functional constipation in infants and children is based on evidence-based guidelines from ESPGHAN and NASPGHAN. And in children who have failed aggressive medical therapy, they need to have other forms of diagnostic testing to rule out metabolic, systemic, anatomical, neurologic, and manometric and motility disorders. Okay. And we would love if you guys could also do a survey, and we are open to questions. Sorry, I spoke a little fast. I wanted to give everybody time to do questions.
Great. So we have 4 questions right now on the Q&A. So I guess we can start with that because it looks like they're addressed to both of us. So the first one is, what is your experience in biofeedback in TENS using either PTNS or sacral stimulation? I know you talked a little bit about biofeedback for constipation, how you don't use it for kids, but do you want to answer that, and I can talk about the urology stuff?
Yeah. So for we don't really use biofeedback for our patients. I've sent them to pelvic floor therapy. With regards to TENS, like the posterior tibial nerve stimulation or the sacral nerve stimulation, posterior tibial nerve stimulation has mainly been studied in kids with fecal incontinence and less in functional constipation, and there's some evidence of its efficacy, though the studies are kind of, they're not the most robust studies, and they don't really have sham studies associated with them. The sacral nerve stimulation, definitely we use sacral nerve stimulation, but there's only a few centers in the country because it's just been more recently FDA approved. And the worry with that is that those are patients truly with true colonic dysmotility or anorectal malformations or Hirschsprung's disease or sacral abnormalities. So for run-of-the-mill constipation, we do not do sacral nerve stimulation. Actually, centers report now 35% complication rates with that.
And for urology, we do use PTNS more often. I have not used it recently. My experience with it personally has been that it's effective in carefully selected patients. I do find that in the patient population that I see with bladder and bowel health issues, that the idea of putting a needle in sometimes is really prohibitive, even though the needles are small and generally to be painful. That's sometimes a cognitive barrier that the children and the parents can't get over. There are more studies about PTNS in the pediatric population for urinary tract issues. Typically, they recommend that you can go through maybe 12, somewhere in the 10 to 12 different treatments on a weekly basis. And most of the studies show good success. I do wonder how much of that is publication bias, and looking at these papers, most of them have a small number of patients. As Lusine said, there's not a sham arm, so they're not randomized controls studies. And there's also children who have generally lower urinary tract symptoms or lower urinary tract dysfunction. And as I said before, that's a pretty wide range. So, it's not just looking at kids with urinary urgency. There's not very strict entrance criteria. So yes, it does work. I think it works in carefully selected patients. I don't use it because it also ties up a room in your clinic for an hour or so, which is, in this day and age kind of prohibitive. But I think that one of the challenges is it's hard to identify exactly who that perfect patient for that is. For biofeedback in the clinic, we do use that. Our nurses typically do it. I think that, again, this is something where if you have a nurse that's very skilled in biofeedback and you have a patient that's very invested and you have someone who's able to really engage and be able to tell the difference and engage in the video game playing with it, for example, then yes, you'll have good results with it. I'm not sure that there's a true ability to tease apart the kids that would benefit from that versus the ones that are almost past that point, because a lot of the kids that we see, by the time they come to us, because our pediatricians are so good at treating this on the front line, by the time they come to the urology clinic, most of them actually need to be seen by GI, and so they have some comorbid GI issues with them, and they really benefit more from pelvic floor physical therapy. The kids who do get biofeedback, we generally do 12 treatments on a weekly basis. The kids who we send to pelvic floor physical therapy, we're very careful to send them to someone who has experience and very specific experience with kids because people, this is very sensitive, and obviously if you don't do well with children, you won't do well establishing a therapeutic relationship with them. But someone who also has very specific training in pelvic floor PT, so not just a weekend course in this, someone who's done a lot of work with it. And at that point, Lusine and I have a colleague who works at the university, and it's actually within the Department of Physical Therapy at the University of Washington. And when we send people to her, we basically turn their care over, like we're consulting her take over the care. And typically it's 10 to 12 weeks, but she's very flexible because we deal with a very large land area. And so she'll have patients that maybe, live 4 or 5 hours away, and she'll give them some homework and see them in 3 weeks. And so she's very flexible about figuring out kind of a curriculum for them, if you will, that helps to meet their needs. But typically it's around 3 months minimum that I tell families they should expect. That was the second question, was how many sessions we suggest. Sorry, do you see that the 10s for constipation question?
So I think for functional constipation, it's not particularly been shown to be effective. So it's used for more fecal incontinence than for functional constipation. And then, as I said about the sacral nerve stimulation, it's not necessarily for functional constipation. It's more for patients who have colonic neuropathy and have failed an appendicostomy because of the high complication rates. And then I think the last question is, in a run-of-the-mill patient with functional constipation, lower urinary tract symptoms, what is your recommended bowel regimen to start, and for what duration? Is there a different regimen for a clean out? So I think that's a great and excellent question. It's actually quite a loaded question, no pun intended. So for a clean out, it depends what your goal is, right? So if somebody, I'm going to approach it to, this is a functional constipation without incontinence. And if you think that they have significant stool in their rectal vault, and that's what's contributing to some of your symptoms, then usually what I do, you can either do a Miralax-based clean out over like a weekend clean out for 2 days, no more than 2 or 3 days, because then it becomes a family ordeal and you'll get complaints. And that's usually based on age and how much they weigh and the amount of Miralax to give. Or if they're greater than age 5, for example, I will have them take, what I have them do is do a fleet enema, a normal saline fleet enema for 3 days, and then that gets all of their rectal stool out. I disimpact them that way. If they're less than 5 years of age, I usually like to do then more of either like a glycerin-based enema or glycerin suppositories. And then for maintenance therapy, depends. Like if this is a medication naive patient, you can always start with Miralax. And if this is only if they have functional constipation without incontinence. And if the Miralax for maintenance is not really working for them, other treatment options is you can add magnesium. There's these like Pediatric magnesium chews. It's like a little penguin on it. And again, that's age-based. You can add on top of the magnesium. And if you're still having difficulty, then your third tier should be giving them Senna, and Senna comes in liquid, tablets, or chocolate XX squares. Usually, let's say a 2-year-old or let's say a 3-year-old comes in, or 4-year-old, they're not potty trained, everybody's very upset. Parents tell you, I've tried Miralax, it's complete hell, and it's just terrible, and it's just not working, they won't poop. I would put that, 4-year-old, 3-4-year-old on half a chocolate square of X-Lax and on potty training and things like that to get them to move, because then the Senna will cause them to have cramping, which will trigger to their brain, oh, I have to go. That triggers me to go sit on the potty than to be able to go. So I'm more of a Senna-based person than Miralax. If somebody's incontinent, giving them more and more Miralax is actually not going to be good. So what I usually do is I actually decrease the amount of Miralax they're getting, and I put them only on Senna. And that, of course, would depend how old they are, how much they weigh, then the doses would depend on that. So hopefully I was able to answer that question. Kathleen, I think you're unmuted.
I was going to say there's one more question. I know we're kind of at time, but is that one that you can answer quickly?
Oh yes, in children with large sigmoid colon, is it advisable to perform a bowel resection to improve function? I would not advise that, because for number one is any of our studies have shown that just because you have a large colon, that doesn't mean that it's not a non-functional colon. So I would want to study that first. So for example, if they have a large bladder, I would never take out their bladder. I would do urodynamic studies and ultrasounds and things like that to make sure before I say, oh, you have a large bladder, so it doesn't work. So for that, actually, I do anorectal manometry to make sure they don't have an outlet obstruction or a neuropathy, and I do colonic manometry to actually inch by inch determine exactly which sections of the colon work or don't work. And then next, if oral therapy is not working for that patient with a large sigmoid colon, then I actually do an appendicostomy, because only with an appendicostomy we have shown that you will get segmental recovery of colonic function as you progress throughout the years. And then if with the appendicostomy they are failing and I repeat the colonic manometry and they still have rectal sigmoid dysfunction, then I will do a sigmoid resection. So after all of those steps. And the reason is because the surgical studies that advocate for surgical resection from the beginning show that those patients probably have withholding or outlet obstruction. So yes, you take a healthy colon and you connect it, and that section becomes distended as well. And I think that's our failure compared to adults. But that's an excellent question.
Well, thank you very much. I know we're a couple of minutes over, but wanted to thank you very much for having us.
Thank you so much for having us.
We're really happy to talk about poop. Yeah.
Thank you.
And if you have any questions, obviously you can contact us and we're happy to answer those. Thank you.
Absolutely. Thank you.